project. I'm very happy that we have such a exciting and increasing achievement in our project, concrete and tangible, I will say, particularly working on the policy level, the strategy and the action plan. But this is just supported by the pilot, so that each of us is developing on each territory. It's really exciting for me because we are really achieving a lot of tangible result. We are using a lot of new option, device digitalization and policy-wise. And gradually we are also going in touch with concrete and tangible action with our stakeholders. So we can demonstrate, first of all, that the need of this project was correct, needed. And on the other side, that we have the skill on board, the tools as well, to deliver something that our stakeholders are expecting that they need. It's really important because we are facing on something related to people, to social issues, particularly elderly people or people suffering from specific disease. And it's really nice to see that from a European project, from a European funds, we can really deliver something of benefit of a real benefit of people on the field. So, as you know, I'm not an expert in these issues. Luckily, I have you on board, the people expert on this field, whether on the social issues, on the policy level, delivering and dealing with people, but also the technician and the ICT aspect for digitalization. So it's really a big place for me, pleasure to be here and to support you. And even if all this talent around, I will be really rude and strict in order to keep the timing. So we have a right timing for everybody and exciting interest for the public, the stakeholder taking part. So that's it from my side. I don't want to waste more time, even if I'm reducing even by 5 minutes my timing. That will be devoted then for your presentation. And so we will start immediately with the first pilot, the one developed by University of Ljubljana, particularly from Samo Dobne and Polona La. Thank you, both of you, even if only Polona is on board. Sam, unfortunately, was otherwise engaged. And I think for your presentation, we will play a video, right? So I kindly ask if you want to start the video. My suggestion, my proposal for you is that in order not to interrupt the presentation, but still to have time for questions, everyone may post the question in the chat. So we can, I will read the question and pose the question, so to have also space for question time, but in a smooth way. So I don't know, Vesna, if you are going to play or who the video of Samo and Polona. Thank you very much.
Yeah, here.
I can ask everybody to keep the mic mute during the, unless you have questions. Thank you. Excuse me? Excuse me, Vesna. Can you stop the...
Yeah, I will, because there's some...
I can hear the audio, but I have people posting that. Can you stop, please?
Yeah, just a second, just a second.
I'm sorry, because I can hear the audio, but I have somebody posting that I don't know if it's because I can hear it properly. I don't know for the others. Somebody was posting that there was not any sound.
I can hear Guido when you talk and when others talk, but when the presentation from Samo was rolling, I couldn't hear anything.
You cannot hear any audio?
From the presentation, no.
Same here, unfortunately. Let me just for a second see.
Okay, I will try to share my video. Maybe from my computer I can share it. Just a second. Just a second.
And 3 organizations from the Ptuj municipality.
Can you confirm if you can hear the video?
In the pilot project,
Yeah,
in the pilot project entitled Accessibility to Integrated Long-Term Care Facilities, we are analyzing various aspects of the accessibility of LTC facilities for elderly. Slovenia is divided into 12 statistical regions at NUTS-3 level. The Podravska region, which was chosen as the pilot project region, has approximately 326,000 inhabitants. That is approximately 16% of Slovenian population. The aging index of the Podravska region is 156. This is the 4th highest aging index among Slovenian regions. The pilot project region has also the highest degree of municipal fragmentation in Slovenia. Here we find the largest number of very small municipalities. Podravska region has 41 municipalities. Most of them has aging index about 100. Among our stakeholders, there are 3 ministries, Ptuj City Municipality, and 3 organizations from the Ptuj Municipality. In the pilot project, we addressed 3 challenges regarding various aspects of the accessibility. The first challenge addresses the special accessibility in the classical view. Rural elderly in Slovenia face with the problem of poor access to public services, especially with the problem of poor access to healthcare facilities. The problem is also the available and affordable transport service for elderly when it is needed. In the pilot project, we identified rural problem areas with poor accessibility to health and other social long-term care facilities where elderly live alone. We present the problem areas to local decision makers and caregivers to organize better integrated long-term care services as well as transport for older people. The map here shows the locations of buildings where older people live all alone. In Slovenia, for example, more than 42,000 older people live alone in their homes, 7,000 of them in the Podravska region. Red dots indicate buildings buildings occupied by older people of 80 years or more, and blue dots indicate buildings occupied by younger older people. We compared these locations with the locations of LTC services and found that there were problematic areas with poor access to LTC services. In general, the areas with poor access are mainly located in the north and in the south of the region. The second challenge addresses accessibility in terms of functionally connected municipalities. The fact is that the most small municipalities are ill-prepared to take on the responsibility of LTC and are not in a position to make major investments on their own. Therefore, they need to join forces for a common investment policy and to create joint public institutions. And, as it has been mentioned before, the Podravia region has the highest degree of municipal fragmentation in Slovenia. In the pilot project, we analyzed possibilities and solutions of functionally connected municipalities, and now we present the possible solutions to local decision makers and caregivers to organize better integrated LTC services. The map here shows a possible solution for the merger of small municipalities into 37 local action groups in Slovenia, or into 18 functional regions. The third challenge addresses accessibility to information. Care for older people is organized through formal and informal services. Nowadays, there are a number of healthcare services that are advertised online, but the offer is scattered and not transparent. Searching for such services is quite time-consuming. To avoid these obstacles, we have designed and set up a web platform where all different providers, formal and informal, would be presented at the same place. We enabled self-registration of service provider as well as special representation of providers via the web. In next days, we will review the entries of informal providers of services for the elderly and include them in the database. We will present the web application to decision makers. This is what the search engine for services for elderly looks like. On the left, a search with text results. On the right, an example of a query and a map for the Podravska region. Currently, we have entries for all formal service providers for the elderly in Slovenia, publicly funded, while the entries for informal service providers in the Podravska region are still being revised. This was a short presentation of the pilot project, Accessibility to Integrated Long-Term Care Facilities, where we analyze different aspects of the accessibility for the elderly. Thank you for your attention.
So, thank you very much virtually to Samo and physically to Polona for this first pilot description. Just a second, because there are some other technical issues, but we will manage it. For me, it's really interesting because we start from the broader vision of what we are dealing with this. Broader vision means the spatial aspect, how to understand where the people are living, which kind of problem are facing, which kind of characteristics they have, age, position. And it's interesting because we are cross-cutting the two elements of accessibility in terms of mobility, physically access, and information. So the accessibility to the information, what we have available, where. And for me, it's a high value what you presented, because on one side, we have a mapping system based on something which is a total standard for any policymaker, for any public administration, so GIS systems, and that we have in every community, or usually we have diffused in every country. So enhancing a link between this solution, which is a standard for policymaker or for public administration, with those links, and then creating a mapping and creating the access to information, a single window, it's a really, really big point. It seems to be so obvious, from the digital point of view, from the technology we are using, but in terms of practical aspect and the consequence we may have on our territory, it's amazing. So I would like to underline this aspect from the starting point, because it's really something that we can learn in the approach, practical, simple, I would say, modestly, but so efficient, because it's really giving, first of all, a larger picture of what's going on. So that is a really good starting point, because from this we understand then what to use in terms of technology, what to plan in terms of organization in settings, and maybe which other data we may collect, use this solution in other countries, but also enrich this solution with other information from other pilots. I'm doing this kind of long speech not to waste your time, but I think it's really a way to look at our pilots also in a way of cross-fertilization among the pilots. So we will be really delighted if all of you, the other pilots, are looking of each presentation and see what can we use, in which way we can create a complementarity and synergy among them. So that was about the first pilot. Now, I have just a second. I don't know if Anna Maria is on board for her presentation, because I have the PowerPoint. Should I share the PowerPoint from my screen, if I'm not wrong? Can you just confirm, Anna Maria, or if there's any movie as well? It's Anna Maria on board? Sorry, because I have contradictory information. I have a PowerPoint. I cannot find a movie to play. Do you know anything, Vesna, concerning? Daria, you know something about Anna Maria?
I don't.
She sent the link to Project Partner 6 yesterday in email with the question if they can play. It's a Zoom link.
Sorry, because I have a PowerPoint. If you can send me the link, maybe I can. Otherwise, I have to skip this presentation and move to the next one. Maybe we can solve the matter. I will check and then. Okay, let's say.
Yeah, we can skip to the next one,
and we will move to the next one. So in this case, now we are moving to more ICT aspect from Josef Stefan Institute. So Mitya, the floor is yours. If you want to share your PowerPoint, suppose that it's about you to present it. I mean, to share the screen.
Indeed. I am the one
I would
to present.
ask you, Guido, if it's not a problem for you to open the PowerPoint presentation, and then the project partners can take control and then
on my computer.
Because
sorry,
you have the latest.
Sorry, if it's possible.
versions.
Mitya, if you can, at this case, just hit to share it, so I can also try to solve the matter with Anna Maria. So while otherwise, I
yeah, of course.
Sorry, Vesna, maybe it's easier like this.
Just give me a second.
Okay, we see. You can put an extended version.
Okay, does it look right?
Yeah, great. Thank you. You have about 6 minutes as well. Thank you.
Okay, so I'll be speaking about a pilot of a mobile application for self-management of heart failure. Congestive heart failure is a disease where the heart can't pump blood adequately to supply the body with oxygen and nutrients. The patients have problems being physically active. They have short breath, they cough, they have swelling because of fluid retention. Now, this is a very common disease, so the lifetime risk of developing is about 20%. And after diagnosis, one can be expected to live about 5 years. It's also a leading cause of hospitalization, so it's a very expensive disease for the healthcare system. It's treated with several medications. Also, appropriate exercise, diet is required. The patients have to limit salt and fluid intake. And all this is pretty challenging for elderly patients. And it's made more so because around half of them suffer from cognitive impairment, and anxiety and depression are also pretty common. So we developed a mobile application that provides comprehensive support for self-management of the disease. It issues medication reminders. It features a personalized exercise program. It educates about nutrition and monitors whether the patients eat properly. It supports them in regular measurements of blood pressure and weight. And it also provides extensive psychological support. It has a psychological evaluation and then guided mindfulness sessions, mindful messages, and games, one of which you can see on the screen. Now, apart from helping patients deal with the disease, it also addresses some more general challenges, which is that the patients don't receive enough institutional support. That's why they actually need an application like this. They see the doctor infrequently. Cardiac rehabilitation is also either not available, or the patients can't or don't want to attend. And telehealth is also not very common. Now, mobile applications such as Hartmann are also not really a satisfactory solution at the moment because their quality is variable. They are often not suited for patients with low digital literacy, and the patients simply don't know what is good and what is even out there. Now, more specifically, we also have to solve through the pilot some challenges of the Hartmann application itself. Now, the application was developed in a Horizon 2020 project, and it's medically validated, but it has some, or had some, usability issues. It also required a psychological sensing wristband, which was technically kind of complicated and also increased the cost quite a bit, and required a backend, a server, and a link to health records, which makes patient enrollment difficult, and it also makes maintenance difficult because it's not all on the patient's phone. Somebody has to take care of the servers. And the biggest challenge was that in the regulatory sense, it was a medical device, and that makes it super difficult to deploy because one has to satisfy all sorts of requirements. So in the first stage of the pilot, we set out to solve these challenges. So we improved the usability. Then we removed the wristband and the backend requirement. We also made some modifications so that it's no longer a medical device, and the removal of the wristband was the main here because if you base decisions on physiological signals, it automatically makes you a medical device. And we are consulting stakeholders on patient needs and usability issues to improve this usability. That is a critical issue in such applications. Now, the second stage of the pilot is done in collaboration with University Medical Center Ljubljana. Here we defined the trial protocol. Then the next step is ethics approval. Then we're going to enroll 20 patients, and we'll have them use the Hartmann application for 3 months. Afterwards, or well, during this period, we're going to evaluate the hospitalizations and emergency visits to see if the improved self-management reduces the number of these. Then before and after this 3-month period for each patient, we'll check the health-related quality of life because the application is expected to improve it. We'll check the ability to manage the disease. We'll check depression and anxiety symptoms, exercise capacity, and at the end, we'll also do a questionnaire about usability, which will compare with usability as was measured in the original Hartmann project, so that we'll see if we indeed managed to improve the usability in the SI4CARE piloting process. Now, the desired outcomes of this pilot are of two types. So the direct outcome is that we'll have a mobile application for self-management of heart failure that will be medically validated or revalidated, that will be usable by elderly patients, and that will be easily deployed via mobile application markets such as Google Play, which was not the case prior to SI4CARE. And we also have some desired policy outcomes. So one of these that we believe would be quite beneficial to patients is to have a curated database of high quality mHealth and care solutions such as Hartmann, from which patients could then choose whatever is necessary for their particular situation. We would like such solutions promoted by health and care professionals, because this way we feel that we can achieve affordable and relatively easy improvement in health and care, much more affordable and much easier than is the more traditional telemedicine that requires heavy involvement of hospitals and other institutions, and also more affordable and easier than is better support by human professionals. So that's it. Thank you, and yeah, you can if you want to know more about this, you can get in touch with us on these emails.
Thank you very much, Mitya, because it's really interesting that you already make the links, even if it's a kind of mapping that we are doing, like by the presentation of those pilots, because you present a device, an ICT solution, but starting from the concept of the cost, beside the impact of those for people, but the cost for health system about the specific disease you are focusing. And then another really important point that you were mentioning, it's the validation to be approved to use this kind of device in an ecosystem, health or medical aspect, which is not something that we can make attempt without caring about the consequence. Therefore, validation is really a key word to enable the usage of certain devices. And the last point mentioning database, service availability, and link a device with other solution, and also link with other data and provide data to them, it's a really important point. So for me, it's really important, this logic that we can map among these pilots, because really we can show that there is a synergy complementarity. So thank you very much from your side. Sorry if I go a bit shorter, but I want to really move to the next presentation. So in this case, I still try to fix the presentation of Anna Maria, maybe we will present, but I think it's more logical if we move then to the next one. So Bojan, are you on board? I didn't receive a presentation yet, so I don't know if you're gonna share your presentation directly.
Oh, okay, yeah, I can.
And then
I can share.
Okay.
Yeah, no, it's uploaded in the on cloud. But
okay.
Anyway,
no
yeah,
problem.
let's.
You can share it. You have 6 minutes as well. We have to catch it a couple of minutes, but we are not so bad.
Okay. You see the presentation and you are able to hear me, I hope.
You can put in extend version presentation. Okay, great. Go ahead. Thank you.
Good. Okay, so hi from my side. I'm Bojan Blažica from the Jožef Stefan Institute, and I will be presenting the pilot about individualized training based on biomechanical measurements. If we look at biomechanical symptoms of aging, we can see that when we get older, we lose skeletal muscle, muscle mass and function. We lose bone mass, and we have impaired proprioception, which is the ability to sense ourselves in space and to control our movements. So basically balance. And this, of course, has some associated risks, which are the decreased strength and power, falls, fragility, less motor skills, and this all leads to a lower quality of life because we cannot do the things that we love to do, sports or other activities, and we are not as independent as we would like to be. We also know we can do something about this. So if we exercise, we can regain muscle mass, and by exercising, we also have other positive effects, psychological and physiological. But when we were looking at the status quo in the region, in Slovenia, we found that both stakeholders and the elderly agree that access to rehabilitation and training services is not at an adequate level. And this is what we're trying to change in the so-called biomechanical pilot. So why biomechanical? Because it's based on biomechanical measurements. Here are a few that we do. These are peak torque and muscular symmetry measurement, tensiomyography, and measurement of body composition. So just a quick example, what we're looking at, we measure the strength of the left and the right quadriceps, and then if both legs are not within 10% of power, so to speak, we develop a training protocol that targets to reduce this gap, because the muscles of the body have to be in harmony, let's say. So how does it look like in practice? The protocol that we use is that we start with an event with a small group of participants, and then we have two different conditions. The first one is in person, and the second one is online. Both last 3 months. In both conditions, we have 2 sessions of training of approximately 1 hour per week, and we do this with a small number of participants so that we can really take care of the details of how people move and perform exercises. So it's almost individual training, but with a social aspect, let's say. And then after 3 months, we have another evaluation to see the change that we were able to make. So in these images, you can see how the initial evaluation looks like. So we do a presentation of the project and also an introduction and education about proper training and exercising. And then this is followed by a consultation with an orthopedist, warm up, so that we can then perform measurement of muscular symmetry. And then this is followed by tensiomyography and body composition. And this lasts 2 to 3 hours for a group of 5 participants. And this is also the first time that the participants can socialize with one another, which we found is really an important aspect of what we were doing. If we look then at a single exercise unit, that, as I said, happens twice a week. This can be broke down to an introductory part where we do general warm-up and dynamic stretching exercises. And then we have 2 main parts. The first one is targeted at activation of the core body muscles, which are important for the general balance. And the second part the second main part of the exercise unit are the exercises where we do submaximal strength training for the leg muscles, and then at the end the final cool down and the relaxation. An important point here is that in the first month of the 3 months, we focus only on proper execution of exercises. So learning the right movements to make the whole training more efficient, but also to prevent damage that we could be doing if exercising in a wrong way. And by doing so, in the second and the third months, we can increase the difficulty of the exercises, and we're also able to do complex exercises such as squats and deadlifts. The online unit consists of the same structure, but we use only things that are available in everybody's home, so chairs, bottles, and things like that. here are some of the lessons that we learned so far. We are now we finished with the first group of participants in person and onboarded the second group, and are in the middle of the first group of online participants. So what we have found out is that there's not enough supply of such services because it was really easy to find participants, especially for the in-person condition. Also, similar project running in the same region had no problems in finding participants. We were kind of worrying that maybe this will be a problem. Also, the online condition is well accepted. One important thing is that working in small groups enables both the positive effects of individual training. So we have 4 participants and 3 coaches, and they can really look at how each of them is performing the exercises and correct them as they go. But also having a small group increases the possibility of have some game dynamics, and this social aspect of the exercising was really well accepted. These groups all went for coffee after exercises, and they decided also to continue for another month after the 3 months that were done within the project.
To the conclusion. Sorry.
Yeah.
Okay.
As we said, 7 minutes, so I have 15 minutes left, I think, 15 seconds. Finally, yes, there was little dropout, only 1 dropout due to unrelated health issues. And finally, it is a pleasure to work with this demographic group because they are all hardworking and grateful to receive the attention given that we can give them in these small groups. So these were my 7 minutes. Thank you.
Thank you very much. Sorry, my clock was showing another minute more. In any case, great that we were mapping and going in depth on the really with patient cooperation, and it's also important that you're facing something that is really relevant for the aging process, so the declining of muscles. And another important point, how practical you were working with a practitioner, with osteopath, or in any case with a doctor or people dealing with the patient, so that we are able to test the device, the solution, not only with people suffering, but also with the right user, let's say, the one that should be included in their process of treating people, taking care those devices. So it's really important that we are not just working like a technician in a theory in a lab, but on the field with the one that are proving that we need to have this and will insert it in the process. So thank you very much for your presentation. Then let's move then from Slovenia to Italy in this case. Pietro, I think you are on board. If you want to start your presentation, or I can share the screen as you prefer. You have also 6 minutes, knowing that as Italian, we will never maintain the timing. So
yeah, you can share your screen. So
okay, I will share my screen, and you can start with your presentation. Just a second. Okay, please. Start.
Okay, thank you. To also the object of the pilot, the title of the pilot of the municipality of Miglina is to study the access to public social services by and enhancing this. So in particular, the aim is to improving the quality and accessibility of the healthcare system, in particular in the remote, in the rural and peripheric area, with the use of ECT. So in particular, so we are studying the enhancement of the telemedicine services and the diffusion of telemedicine services, telemedicine, teleassistance, and tele-home care in both in our little town municipality of Miglina, also in the neighboring municipality in our province. So currently we are ending the step 1 of the pilot activity, and this we selected the wearable devices, in particular some medical devices. So we also approved by Calabria region in order to be completely aligned with the country rules. So, and we are starting this step, the procedure for buying this, and then we will deliver in a second step in a sample of patient with other stakeholders. So, and then in the second step, we will use such the device to improve the efficiency. So of the study. So this is an iteratively beginning process. So in which place we will implement the pilot? So in several municipalities joining Miglierina, in a little town near to the services. So we also involved the UCCP of the Reventino. This is joining is an association among medical doctor, community medical doctor, and we also involved to the Ragionlus and the Comunità Progetto Sud. There are two association, non-profit association, they take care of elderly and in particular people with dementia. So what we learned in this step. So initially we know are resistant with to the change. So it's not easy to propose new initiative. In particular, is not easy to propose change to medical doctors. So they are they have their rule, and so they recognize that you have to change, but they don't want. It's not too easy to change. But on the contrary, we also on the elderly people and on the association are relatively confident towards some solution, in particular with branded solution that may be easily also recognized to the Calabria region. So in Calabria region, in Italy in general, so the laws about the telemedicine are in progression. So people is more confident with branded solution with respect to ad hoc solution. So, but as we are confident because this is a possibility to extend. And in particular, so I will show some the devices. So this is the first device is a bracelet equipped with an SOS button in order to call the services. It's also able to monitor some vital parameters. So the cardiac frequencies, such as the pressure and so on. Also, it has also a GPS sensor in order to monitor the user position. It's also able to monitor the movement of the people. So it can also be used with to monitor the ICF, the status of the people. So can you move on the next slide? So okay, so okay, see this. So it's also may measure the l'actipedometer and the barometer, so the activity parameter and the environmental parameter. So it can also be used to monitor the people with dementia, so the progress and the status, also in rehabilitation scenario. It also can remind to other people, oh, it's time to get the drug, the medicine. So from a technical feature, so it's based on three main pillars: the GPS to send the position, the emergency call, a geofencing in order to also analyze the movement in a closed environment. It can also some type of alarm, so it may be also easily customized. So on the website we present on, you can find some more parameter. So can you? Okay, so this is the.
If you can speed up a bit because we are now exceeding. Thank you.
Yes, yes, this is the overall step. So the device will be put in Ragionlus Comunità Progetto Sud. Medical data are managed by medical doctor, and we also all the data will be collected into the EDUs and our DSS to monitor the pilot. So this is the main idea. So we plan to involve at least 30 patients and then to extend the network in the project. So thank you, Guido, for the for sharing. So thank you all to.
Thank you, Pietro, as well. Sorry if I was so quick or so pushy, but time running. So I will move then immediately to Katia from Technical Institute of Public Health, Split Dementia County.
Teaching
if you want to start with your presentation.
Yes, please, but it's Teaching Institute for Public Health. just to correct you.
What did they say? Sorry.
Yes, it's okay.
Okay, so in any
Can
case,
you
I'm
please?
sorry for wrong. So should I share the screen as well? Okay.
Yes, please.
You can start in any case in the meantime. Sorry, just a second, because I had another PowerPoint.
Okay,
okay, here is. Okay, you can start.
I can start with mine.
No, it's done. Okay. Yeah.
Okay. Okay, so the title of our webinar is Nursing by Monitoring, Institutional Timely Reaction of Services. Sorry, where can I move it? Here?
No, you cannot move it. I have to do it.
No, I think she can just need to press the button at the in the corner at the beginning. There's the button that says take control. So if you press it, you can then cut it.
Should I do anything, or she has to?
She has to.
This is okay now. Can you see it?
Okay.
Is this okay? Can you see it?
Okay, you are sharing your screen. It's fine. Okay,
yes.
No problem. Okay. Okay.
Okay.
You can see, and you too. Okay. You can present it. If you can extend the presentation, then you are sharing your screen directly. So okay.
Yes, I am. But can you see it?
Yeah, we can. Just put in an extended version.
Now?
In the presentation form, if you can.
Like this?
No, on the bottom right, you have a small button, presentation. It was okay, the sharing, just you have to extend the PowerPoint.
But I did.
Okay, let's go like this. Doesn't matter. I think we can see in any case. So
okay. Okay, I hope you can see. So wait just a moment. Now I will start with methodology for pilot management and reporting, saying that sorry, just a moment. Now, is it okay? Can you see it in a full?
Yeah, it's okay now.
Yeah, it's okay.
Okay, now, because colleague helped me. Okay, so framework for this project step document is named Implementation of Integrated Pilot Action Telemedicine. We divided our implementation of pilot into 3 phases. Preparatory phase, which we ended, implementation and monitoring phase, in which we are now, and closure phase. In the table below is shown what we have done until now. It is in blue fields, and what is in progress, now it's in yellow fields. So when we speak about context analysis, status quo and best practices, we must say that we collected data at several levels. So it's general public, stakeholders and public authorities. And our aim was to establish the current health status of the elderly population regarding their health care in Split and Dalmatia County. So we established several challenges. That is to say, the lack of human resources, technological equipment, infrastructure, specialists in geriatrics, relevant legislation, and so on. Based on these needs that we identified, below you can see best practices of all project partners. And on the right side, you can see our best practices, that is of PPO4 and PPO5. When we speak about context analysis, we must say that analyzed best practices showed that IoT technologies can be used to increase elderly healthcare. So we choose for our pilot smart bracelets in order to gather health data as an early warning system. So this collected information can help us in diagnosis and possible prevention. How? It's a real-time monitoring system that acquires data, and it has a possibility to alert if values determined should exceed threshold values. This system is mobile. It means it can be used from remote, of course, with the use of internet access. our nursing home Lorvet was chosen as a pilot location. The first 2 floors were chosen, selected for pilot implementation and testing technology, and the current IT infrastructure can be upgraded. What is important that the nursing home employees will be able, after implementation, to monitor vital signs of their residents in real time. It means that the data delivery will be every 10 minutes. Sorry, the picture is missing. Because here you were supposed to see.
Can you press? Maybe it's coming. If you.
Maybe it's coming. Yes, it's coming. Sorry, unlucky me. Okay, so technical requirements. Here you can see that once more. So we used these COD Smart bracelets. What is important is connection between them and the receiver. And it can even go to, despite barriers such as walls, floors, something like that. And sensors that we are measuring refer to heart rate value, wrist temperature, number of steps, position, seeking help, even man down, which is very important, for example, as a fall prevention sensor. Okay, now I learned how to do it. This is graphics of finally technology used, and the main reason for selecting exactly this one technological solution is that this is the one with high quality performance in connection between bracelet and receiver. As I said before, despite physical barriers such as walls or floors. Once again, I need to mention challenges. So we established challenges, and according to these challenges, we defined objectives. What we all know that infections among elderly, unfortunately, very frequent and required prompt reaction. So we had to choose the appropriate technological solution for this pilot implementation. We wanted to ensure that vital science data measures are delivered in accordance with elderly's habits and their routines. And also to take in consideration GDPR regulations that is in progress now. So when we speak about objectives, early and timely intervention, as we know, can help reduce possible complications. So it can be achieved using exactly these IT devices, monitoring the elderly at regular intervals. What can it enable, this monitoring? So we can address health risks. We can contribute to efficient, timely and appropriate interventions. It is important to say that these bracelets are very simple to use. They are suitable for elderly population, but they can even be upgraded if necessary during this pilot phase. And I mentioned that two times before, that the reception is very good despite physical barriers. Lorvet employees, together with us, public health experts and technology experts, will provide a high-quality implementation, as we hope. And what is very important to assess also is the technology acceptance among the elderly. Recently, we have had this meeting, as you can see, at the nursing home Lorvet. It marked the beginning of our implementation, and the technical specifications have been tested. They're in line with our expectations. During the meeting, we discussed about project objectives, bracelet use, they're accepting it, how to use this IoT wallet, and consider some next steps. This is where to contact, and thank you for your attention.
Thank you very much. Also, you take over the little technical issues. So I think now, I don't know, Vesna, if you take over the presentation, maybe. So it's to avoid this kind of elements, can be. In any case, so thank you very much, Katja. And now we move to Vlatka now. So for your presentation, if I'm not wrong, are you?
Good morning, everybody. Thank you, Guido.
Hi. Just to know, if
I will
okay,
share
great.
the presentation. Yeah, do you see it?
If you can go on presentation mode and not preview. But okay, otherwise it's okay. Okay, we can start. Vlatka, please.
So the title of our pilot is Access to Public Health Services. On the beginning, just a short introduction about the situation in our country. The centralized healthcare system of Federation of Bosnia and Herzegovina is one of the many reasons for the lack of data on leading disease in the elderly population and the provided health services. The Federation of Bosnia and Herzegovina is composed of 10 cantons.
I'm sorry. Are you controlling the presentation, Vlaka?
Vesna is, okay, I'll do it.
No,
okay.
No, not to share the screen. You can move. Okay,
yeah,
Thank you.
I shared this one.
Thank you.
So the Federation of Bosnia and Herzegovina is composed of 10 cantons which have individually regulated health system with their records and database that are not interconnected. The data collected from the healthcare institutions in Federation of Bosnia and Herzegovina will provide us with information on leading disease and the treatment costs in the elderly population. By analyzing the current state of healthcare for the elderly population, we will offer solutions for improving the healthcare of the elderly population. The main goal is to identify system weakness and plan better healthcare for the elderly population. This will be possible by collecting data in a common database, which will allow to achieve 3 specific goals. The first one, enable the data on health services provided in healthcare institutions in Federation to be contained in one place, and it will be easier to see which services are provided to the elderly population. The second goal, to plan process for services provided will be facilitating and insight into the key problems of providing services to the elderly population will be provided. And the third, solutions will be proposed to the competent institutions to improve the accessibility of health services for the elderly population. In order to achieve the main goal of the pilot, it is necessary to develop a unified database on diagnosed disease and provided health services to elderly population in the Federation of Bosnia and Herzegovina. Based on the data from the unique database of health services in Federation of Bosnia and Herzegovina, solutions for better medical treatment of the elderly, better provision of the health services, and suggestions in creating health policy would be proposed. The pilot database will be the starting point for creating a database on the territory of Federation of Bosnia and Herzegovina with the contribution of SHS, which will help the Ministry of the Health in creating a health policy for the elderly. So thank you very much. This was a short presentation of our pilot.
No, it's great in any case, even if time-wise, I mean, we take over some little delay, but it was really important for me because we are looking at a national level, a nation which has, as a federation, a lot of issues concerning. We were discussing many times about this point, and our data are really the basic for policies on one side, but really important also to provide a vision about the service provided and the planning of those. So it's really another really important piece of this puzzle that we are mapping now with our pilots, and now we are dealing with each issues, and we have to benefit also on this, because it's not said that it's only your problem, let's say. It is about the data and how to present it and share it, but it's a common element in other countries. So I would say that's really beneficiary to gain a lesson from your experience as well. So thank you very much for your presentation, Vesna. And then I will move to Greece now, if I'm not wrong, the colleagues from Athens. Demosthenes, Pavlov, is it you on board now? I think Vesna is also sharing the PowerPoint, your PowerPoint.
I will, just a second.
Hi, Demos.
Yes, thank you, Guido.
Yeah.
It's Pavlov, not Pavlov.
I'm sorry to everybody, but I have a really small letters. They were preparing this agenda. I have no glass with me, and elderly people are facing this kind of problem. So yes. I apologize to everybody for mistakes on names, institutions, and so on that I should, by the way, know by heart. But this is another issue about us elderly people. So I'm looking forward for your support, starting from my driving lessons in future. So it's yours, the floor.
Okay, thank you. Do you want me to share my screen or?
I don't know, Vesna, are you going now regularly for each one? Who is gonna? Vesna, you? Dimos? Just
I
tell
think
me.
previously.
Yeah, I will. I thought I already shared it in just a second. Here you go.
I think
Okay,
you're
I can
sharing
start.
another screen. You're sharing another screen, maybe, Vesna. Okay, fine. Dimos, please.
Okay, I'm going to present very briefly a pilot that we're running here in Greece for this project. If we would put a title, it is self-assessment of driving behavior as a predictor to safe driving for the elderly. So, very few words about the background, the literature review, what we know already. We know that driving, we focus on driving, first of all. We know that driving is a very complex task, which requires the ability to receive sensory information, process this information, and to make some proper and timely judgments and responses. In parallel, we know that advanced stage affects the ability to drive in a significant way. It deteriorates the ability to drive and may lead to reduced driver fitness to drive and reduced reaction time, increased reaction times and increased accident risk, accident probability. Now, the mechanisms and the tools for ensuring who is fit or who is not fit to drive and who drives safely or not is not very clear in Greece and is not very clear in many European countries. So there is a lack, there is a gap of a unified, valid and easy to administer procedure with ecologically valid guidelines that can be applied to the several stakeholders or the practitioners and everyone who is involved in the driving license renewal procedures or recommendations for the older drivers. So which is the aim of this pilot? The aim is to obtain some practical knowledge that will improve the existing driving recommendations in order, if we can move on to the next slide, in order to enhance the driving safety among the elderly, focusing on the elderly over 60 years old. And how we're going to manage that? We're going to correlate a driving behavior questionnaire, self-assessment driving behavior questionnaire, with a lot of indicators of older drivers who completed a driving simulator experiment. A few words regarding the driving simulator experiment. It concerns the assessment of driving behavior by means of programming a set of driving tasks for different driving scenarios. This is a photo. We missed that. This is a photo from our driving simulator. An older driver is taking the test in this photo. You can see that we have 3 LCD wide screens, full HD, 42 inches, with a total field of view of almost 180 degrees.
Sorry, we don't see any photo, Dimos.
Yes, but I can describe it in a way that it's like you are going to see it.
Okay.
Yes. If you would like, I could share my screen. It's not a problem for me.
No, go ahead, because we are done
yes,
now, so with this technical aspect.
Yes. And it is important to highlight that this simulator is validated against a real-world environment. We have made, let's say, a research, a project in which people who took the test, who drove in this driving simulator, afterwards drove in a real-life experiment, and we saw that the driving behavior indicators from the simulator are correlated, are very close with what the real experiment concluded. So, what was very briefly the procedure of the experiment, if we move on? First of all, they drove one practice drive, approximately 15 minutes. Then they drove one rural route and one urban route, outside urban area and inside urban area. And what was the advantage of having this simulator experiment is that we had the opportunity. You can move on to the next slide. We had the opportunity to program, to schedule, to design 2 unexpected incidents to occur during each trial. If we speak for the rural drive, we scheduled the sudden appearance of an animal entering the route, and in the urban scenario, it was the sudden appearance of a child chasing a ball, which is an unexpected, of course, and a common issue, very possible to happen in an urban area. I don't see that we have moved on. Can we move on to the next slide? Can you hear me?
Yeah, but you can also move the slide, Dimos. You have the arrow. You can press and move the slide as you prefer.
I didn't know that I had this opportunity.
Yeah, that was okay.
Sorry for
no problem. No problem.
Yeah. Okay, these are 2 screenshots. Here you can see the deer entering the route, and we didn't ask. The driver should brake in order to avoid the accident. And over here, in the figure below, you can see the child chasing the ball in an urban area. So, in total, 125 participants, all more than 55 years old, and of similar demographic characteristics, went through this experimental procedure. We had 34 healthy controls and 91 patients with some kind of neurological disease, MCI, Alzheimer, or Parkinson's disease. This was the experiment in the simulator. Now we have the questionnaire. All these participants filled in the questionnaire. We had more than 100 self-assessment questions regarding their driving behavior. For example, a question which was, which are your strong...
Sorry, Dimos, because we are exceeding the time a bit. So if you have still other 3 slides, as I see, if you can speed up.
Well, I just want 1 minute. 1 minute. Okay. We asked them to assess their driving behavior, strong and weak abilities. In comparison to 5 years ago, how would they assess their driving skills? So, what we want is to analyze, to make correlations between their driving behavior in the simulator and the self-assessment questionnaire, and to find out which 5 or 6 or 7 questions out of the questionnaire are most highly correlated with their driving behavior, their reaction time, their speed, their lateral position, their accident probability, in order to use these questions for future assessments, and maybe we would be in a position to classify this driver into safe driver, or maybe it is at risk. So further evaluation is needed. The wish list to be tackled are, first of all, the accessibility of the elderly in remote areas to specialized healthcare through telemedicine, because all this procedure, the questionnaire, can be done from distance, and the consultation of caregivers of patients with dementia through telecare. Again, some elderly who lives in a rural area could take could fill in this questionnaire, and some recommendations regarding his or her driving behavior could be extracted. This was the idea. The final goal is the proposal to the Ministry of Health about the necessity of a driving consultation service for the elderly, which now is missing. Thank you very much.
Thank you, Dimos, for your timing. So I will move immediately then to take over to Evangelia. In your presentation, I think still Vesna is sharing the screen, and I underline that you have a possibility, Evangelia, to use the arrow on the bottom of the PowerPoint to move by yourself the slides. Just a second. It's going to be shared now.
It will be in just 2 seconds to upload it. Yeah. The floor is yours.
You see the arrow on the bottom, Evangelia, and better if you switch on your mic. That will be more understandable. If you can switch on the mic.
Okay, sorry, no.
Okay, fine. We can hear you. Go ahead with your presentation. Thank you.
Hello, nice to see you, everyone. I'm trying to switch the slides right now, but they don't. So is this like, okay, I'll try once again. Oh, okay. Everything all right. Perfect. Thank you very much. So I'm going to talk to you about tele-exercise for the elderly and patients with cognitive disorders, dementia, which is our second pilot activity. So a general background would be that from what we've known, physical activity is a non-pharmaceutical, well-established intervention for the elderly with cognitive disorders, dementia, and movement disorders. And it mainly the main effects include the improvement of mobility and fitness, falls prevention, improvement of cognitive functions and everyday functionality and quality of life. It is also very supportive in terms of socialization of elderly population because the elderly can have the chance to interact with specialized staff and other elderly when working in groups. So the interlink with our status quo and challenges is that the elderly of remote areas have limited access to secondary and specialized healthcare, as well as other social healthcare services. The use of new technologies for the care of the elderly is extremely low from what we've seen from the status quo and challenges. And we know that Greece has many small and isolated islands and mountainous areas with high percentage of elderly inhabitants. And so a lot of those places are understaffed in terms of healthcare centers, of healthcare providers, and providers of social healthcare. One more reason is that COVID-19 pandemic increased the accessibility issues that were already existing. So our objective was to design and implement a specialized online physical activity program for elderly patients with cognitive disorders, dementia, and movement disorders. So this was designed by the first Department of Neurology of the National Kapodistrian University of Athens here in Genitio Hospital, in collaboration with our partners from the Department of Experimental Physiology of the Medical School and the second Regional Healthcare Administration of Piraeus and Aegean Islands, the Greek National Telemedicine Network. In terms of the KPIs that we were interested in, I'm going to refer to the patients of quality of life, the health outcomes, patients' satisfaction from the provided services, the general improvement of physical state as measured by specific indexes, and improvement of emotional state. So our methodology was that we were going to recruit individuals above the age of 65 years old and elderly with cognitive disorders, dementia, and movement disorders, that they were going to participate in small groups of people of maximum 10 people. Tele-exercise intervention was designed in order to happen in terms of frequency 2 to 5 times per week. Each session had to have a duration of 40 minutes per intervention, and the type of exercise was going to be aerobic and resistance training in accordance with the WHO guidelines, the World Health Organization guidelines. This program is implemented by our partners, specialized healthcare professionals of the Department of Experimental Physiology of the Medical School. So during the preparation phase, the main activities that we encountered was the ethical approval from the Medical School of National and Capodistrian University of Athens, the development of a battery of psychometric tools and a satisfaction questionnaire regarding the patient's satisfaction from the provided services, selection of the appropriate physical fitness assessment tests to be administered, tests for the online adjustment of the exercise programs, and of course, quality evaluation of our technical equipment. During the implementation and monitoring phase, and the stakeholders that are participating in this until now, I would like to refer that to the fact that we've started since January 2022 with one group of 10 elderly people without cognitive disorders or movement disorders. They have been participating in a tele-exercise intervention in collaboration with the doctors of the world. The elderly involved in this program were trained to use the tablets because they are connecting to the programs through tablets. And all participants until now report high satisfaction rates and improvement of functionality in everyday life. We established the collaboration with the doctors of the world, a stakeholder for us, and we prepared and submitted abstracts about tele-exercise to the European and national congresses in order to inform and disseminate the information to more healthcare providers. And we also designed and administered a poster to the inhabitants of the Aegean Islands. We have through the mobile medical units. So the key results and lessons we learned till now is that tele-exercise is a feasible and effective, innovative, non-pharmacological treatment that enhances social interaction because those people are training in groups. There is an effective collaboration between healthcare providers that is necessary. Satisfaction questionnaires showed that there's a great satisfaction reported till now. In terms of KPIs, we saw that health outcomes, patients' quality of life were increased, and that we also saw that there's improvement of physical state and improvement of emotional state as reported by the participants. And in terms of complaints, although we really tried to train our participants to use the tablet in order to connect to the program, they still face technological difficulties. So just one last slide. In terms of policy issues and planned activities, we would like to have better legislation protocols for the provision of innovative social intervention programs like tele-exercise services, adjustment of national public spending in order to provide grants to healthcare facilities to upgrade and receive up-to-date technological equipment in order to be used for tele-exercise services. And we also would like to have a contribution by validating the usefulness of specialized tele-exercise services in the elderly, disseminating all the outcomes from our outpatient clinic in collaboration with the National Telemedicine Network and this social intervention in order to learn, to disseminate more the information about our programs, and engage healthcare stakeholders to apply specialized physical activity programs in their region, especially in remote areas. Our planned activities are to increase the awareness of the importance of tele-exercise interventions in the elderly and disseminating the information through online meetings, social media, newsletters of medical societies and scientific congresses, enhancing our collaboration with the telemedicine pilot program, our pilot Action 1, and creating an electronic database for entering and collecting our data. So thank you very much for your attention.
Thank you, Angelia. for your presentation. It's again really important because we are dealing with now a specific disease in a context, and I will use this opportunity to try to show the video I get from Anna Maria, even if there is a problem because she was not scrolling the presentation, but at least we can merge the two issues related to dementia in a short nonset. So I will try my best. Let's see if I can share my screen with the audio. Just a second. Even if the PowerPoint will be not presented. Just a second, just confirm.
I will present the pilot, which was done in Slovenia.
Can you hear the presentation?
And it was about opening the units
Yes.
for residents with dementia in the care home. So aim of the pilot project was to open new unit for residents with dementia in existing care home, which brought by itself also problems. It is easier to build a new care home that you know what are the needs of the residents, and you are a little limited in existing special environmental possibilities of the existing care home. But with the raising number of residents with dementia, it is also raising need for new places and new units. Not all residents with dementia are living in special units, but those one who are more active, who need more support to be to go outside for the walking. So these are residents who are not yet in the wheelchairs or in bed. The second aim was to implement existing care model to the more congruent model and to encourage non-pharmacological care. We have in Slovenia some care homes who have more medical model, and I could say majority that are implementing into more social model. We could saw this by COVID phase when those medical care models were really locked up for very long time, longer than those ones who have also social model. So the aim was to educate the caregivers and nurses to implement existing model, to have permanent care teams, to start delivering also non-pharmacological activities. The third aim was to improve relationships with relatives. That relatives are not someone who is controlling the activities in the care home, but that we all are partners, and relatives have a very important role in the process of the care, and also to make analysis of the pilot. These are some pictures that were done. The renovation of the unit, it was not opening only one unit, but we also renovated 2 existing units for people with dementia. It was done by the end of 2021. We can see long gray corridors, which are very hard for people with dementia to orient it. And people had problems how to get into their rooms. We have painted some different trees and then placed also some fruits like apples, pears, plums, so people can have also activities by walking on by the corridor to place or to take some fruits. You can see also very limited space for the residents. They could just sit down and there was no place for walking or going around. And then we put some special reflexotherapeutic way, and people with dementia can go in the socks, and they have also gardening, possibility of gardening, sitting, and we also placed animals and different activities. Young social worker also developed some Montessori activities. We placed whiteboards on the corridors, so people can just take different activities, but they are not somewhere in the wardrobes or in the locked rooms. So if we look at the summary of the pilot until now, of the pilot activities, it was finished renovation of 2 units for residents with dementia. It was open new unit for residents, and this is for 33 people altogether. The care home is other way, it is 157 residents. It is that number, and we finished education of the staff about importance of care model, about importance of relationship with residents, of permanent teams, of knowing the residents, of knowing their story, their biographic story, their habits, their wishes, their activities, what would they like to do, so they can have better relationships. And the importance of personal planning also, that the personal plan is made with the person, with the resident, with relatives, and also that is known to the relatives. The importance of non-pharmacological care and non-pharmacological activities that must be daily used, that must be regularly delivered, and it was made analysis of changes. And then raising awareness in local community with Alzheimer cafes and in media. The DEOS Center Starejši, this is Center for Elderly, also employed 2 new social workers, and this is a huge impact on improving, implementing the existing care model. What is the change impact? Implementation of care model, new units for residents with dementia, destigmatization in local community, and less antipsychotics for residents with dementia. Yes, we could say that everything is great, everything is really great, but there is a threat that someone has to be all the time encouraging that those changes will really stay. Thank you.
Again, virtually thank you to Anna Maria, even if we had this technical problem that the PowerPoint was not presented actually, but at least we had the speech. And I apologize once more also, Eftalia, that I was postponing her presentation, and the logic may be among the 2 Greek pilots, but it was also to create the cluster of dementia issues in our project. Therefore, I was inserting this one. So, Eftalia, the PowerPoint is ready. You can start and take on control. Thank you very much.
Okay, thank you. Thank you very much, Guido, and everyone for moment. So I will present the 3rd pilot of our program, named Specialized Outpatient Clinic for Memory, Dementia, and Parkinson's Disease through the National Telemedicine Network. So first of all, as a general background, we all know that dementia and cognitive impairment are very frequent disorders, and they refer to about 20% of the population above the age of 65. And as literature evidence has shown, telemedicine is a reliable tool for this kind of disorders and improves the access to healthcare. So now I would like to make an interlink with status quo and challenges. First of all, the elderly, as Evangelia said, of remote areas, as we found, have limited access to secondary and specialized healthcare. The use of telemedicine and new technologies for the care of the elderly is very low, and Greece has very small and isolated islands with limited access to specialized healthcare. So we based on these main 3 best practices. First of all, the National Telemedicine Network of Greece, the Telepsychogeriatric web-based program, and the mobile medical units. And based on this evidence, Our objective was to design, organize, and implement an outpatient clinic with the aim to improve the access of the elderly with cognitive or movement disorders who live in remote Greek islands to specialized healthcare services through telemedicine for the timely diagnosis, appropriate treatment, and regular follow-up. So during the preparation phase, first of all, we made meetings with the head of the National Telemedicine Network and the head of the Second Regional Healthcare Administration of Piros and the Aegean Islands, and a collaboration between them was established. And based on our experience in the Aegean University Hospital and the Hellenic Dementia Society, with discussions we made with them and on the existing literature. Now you can't see the presentation, I don't know why. I don't know what happened, I'm sorry.
Vesna, or you were switching on the sharing?
Do,
can you share it again?
Share it again, yeah, no problem.
Thank you. Okay, let me go on here. So yes, based on also on existing literature, we developed the parts of the neurological and neuropsychological assessment that can be administered online. We took an ethical approval from the first Department of Neurology. And firstly, we made some informative online meetings with the healthcare providers of the Aegean Islands through the National Telemedicine Network. We've examined also 2 individuals, and we also developed the satisfaction questionnaires that we're going to provide to the patients, the healthcare providers, and also their carers. Okay, our KPIs are the following. First of all, we will see the number of patients evaluated, the mean length of appointment waiting time, the rate of patients' complaints, the patient satisfaction rate, and the satisfaction rate of caregivers and the healthcare professionals. And as Daria proposed in the previous meeting, we would like to also incorporate some KPIs from the other project partners, for example, Anna Maria, since we are thinking to make some interviews with the patients and the carers, how to tell us some feedback also, apart from the satisfaction questionnaires about the program. And we are going also to incorporate these KPIs based on the other project partners. Now, regarding the implementation and monitoring phase, we have done some problem-solving discussions with key stakeholders from the National Telemedicine Network from Greece, so from the mobile medical units, the Athens Alzheimer's Association, the Doctors of the World, the health centers and hospitals of the Aegean Islands, about some issues regarding drug prescription, sharing, how to share MRI files more effectively through online, or how to increase the referrals and make more incentives for the healthcare providers in order to participate in this program. In addition, we submitted some abstracts about the SI4CARE project and also this pilot activity to the European Academy of Neurology Congress and the National Neurological Congress and the National Medical Congress in Greece. And in addition, in order to inform the other healthcare providers more about this pilot activity, we managed to incorporate this activity in the newsletter of the Medical School of Athens and the Hellenic Society of Digital Medicine. In addition, as Evangelia said, we have designed a poster in order to be administered to the inhabitants of the Aegean Islands through mobile medical units, which is a best practice we had said before. And we also established a procedure in which cerebrospinal fluid could be sent from the islands in some general hospitals, for example, in Rhodes, in the island of Rhodes, could be sent to the laboratory of the Aegean Hospital for further examinations to be done here. For example, to measure some biomarkers for the differential diagnosis between Alzheimer's disease or frontotemporal dementia, for example, and blood samples for DNA testing for some atypical presentations, so for dementia cases with earlier onset, of disease. Wait a minute. Okay, so till now we have made 58 telemedicine examinations, of which 39 are new patients, and we have also done 19 follow-ups. We have received until December, we have analyzed these questionnaires. We're going to analyze also the rest of them. Until December, we have received 27 questionnaires with a very high mean of satisfaction with this kind of examination. And the mean waiting time was about 1 week. So this is a table that shows separately the mean satisfaction rate from the caregivers, the patients, and the healthcare professionals. And we have included 10 questions. For example, do you think that that telemedicine helped you for better access, for improved access to specialized healthcare? Or do you think that the doctor make you understand some issues about your health? It was convenient for you, questions like that, or also about reduced costs, reduction of transportations, adequate follow-up, if, to their opinion, if the medical assessment was reliable, if it improved their general health, and if they would select telemedicine in the future. So our lessons till now are the following. First of all, we confirm that telemedicine is feasible and effective also for the Greek population of the Greek islands, and it improved the diagnosis, treatment, and treatment of the patients. And it was also an opportunity to inform them about some non-pharmacological treatments, which are very important. For example, exercise, social interactions, that we show that these kind of activities are many times neglected from the primary healthcare practitioners. In addition, we show that an effective collaboration between the healthcare providers is necessary. The patient's perspectives are very important to consider for further improvement. For example, some patients told us that more residents of our islands need to learn about your clinic. So it means that they're not informed about our clinic. And this is definitely a reason for the small number, the relatively small number of referrals. Generally, they were satisfied. They told us to keep the important work, and then asked about more medical specialties that could be done through telemedicine and more regular follow-ups. And something important is the fact that we also mentioned that the identification and referral of rare cases to the university hospital for more specialized examination is feasible. Some policy issues is the issue of legislation protocols that still, at least in Greece, the last legislation protocol about telemedicine was in 2011. Until now, nothing more specific has been done. In addition, it is very important the expansion of the use of telemedicine, and in particular specialized telemedicine services for the elderly in other medical specialties and other regions. And our planned activities for the future involve, firstly, to increase the number of referrals, and this could be done by increasing the awareness of the importance of telemedicine through maybe online meetings or social media or more newsletters. In addition, we would like to provide educational webinars to the healthcare providers of the periphery about how to treat and to diagnose these patients better, and to collaborate with pilot activity 2, in which Evangelia presented before. And we also plan to send a formal proposal to the Ministry of Health regarding the legislation issues. And finally, yes, of course, if you have any questions, you can contact me also. Thank you very much for your attention.
Thank you very much also to you. We are quite in line with the timing, and I'm so happy that we were clustering these issues about dementia among 3 pilots, let's say, and how all the other, let's say, aspects in the framework for our project, ICT policy, data, and so on, are going to be really complementary. So it's nice that we have a focal point so intensively focused among 2 countries first, and now the other elements obviously can support this to be taken. So thank you very much. Then let's move then to the next presentation. Now we move to Serbia. If I'm not wrong, we are moving then to Nena, is correct? You're going to present your PowerPoint already available from Vesna screen. So you can use the arrow below the presentation. The floor is yours, please.
Okay. Hello, everyone. Good day. Allow me to greet you all on the behalf of Special Hospital Merkur from Vrnjačka Spa, Serbia. And let's introduce myself. My name is Dr. Nena Stevanović. I'm doctor in Special Hospital Merkur. And I'm going to tell you something about ICT solution for monitoring the health of patients after returning home. For the beginning, let's see the brief description of the pilot. Pilot location is in a special hospital for treatment and rehabilitation, Merkur. I must say that Special Hospital Merkur is a national center for diabetes until 2008. And most of our patients are suffering from diabetes. Patients, those who are involved in pilot, are already patients in our hospital, and we have the full medical document about those patients, and we have also those documents in our medical IT system, and finally these data are transferred to the pilot application. Pilot will determine if it is possible to influence the health condition of the elderly by telemedicine. In other words, deliver care to Merkur patients at a distance when they return home. So the stakeholders involved are the following. Mobile network operator was in charge of software maintenance. Then Medical Faculty of Kragujevac was in charge of participation in defining the clinical study procedure. Pomaranje Kraljevo was in charge of dissemination and social network campaign. And Pahuljica team Kruševac was in charge of organization of promo events. The initial steps were status quo, analyzed together with stakeholders and associate partners, which was followed by identified challenges arising from the status quo. And this is our wish list. Development of telemedicine for healthcare services to reduce cost of healthcare services, and finally healthcare services at home for elderly in rural areas. As an example of best practice, the project Smart Care set out to define and pilot a comprehensive set integrated health and social care services to overcome a range of threats to independent living commonly faced by older people. We have completed the following activities. The identified best practice Smart Care was redesigned to specific context of Merkur. Pilot preparation was forming a medical team, education, providing equipment of ICT solution, campaign to inform the target public about new services. Of course, installation of ICT, testing, validation, service startup and operations. Establishing a methodology for medical consultations from home, call center, internet communication, frequently asked questions, online consultations, education of medical and non-medical staff, medical staff organization like call center and shifts, patient recruitment, and monitoring of project results and corrective actions. These are the activities that need to be completed. Involving medical faculty Kragujevac in clinical study, formation of 2 control groups of patients to compare results, involving NGO Pomaranje for internet communication to attract patients and Pakuljica team for promo events, post-pilot evaluation, analysis of results, examining patient satisfaction, plus associated partners. And finally, pilot closure. This is the change or impact that the pilot action had, breaking down prejudices among medical doctors about the applicability of telemedicine, developing patients' awareness of the possibilities of using telemedicine, establishment of a working group in the Ministry of Health regarding the analysis of the possibilities for telemedicine application in Serbia, and finally increasing the interest of stakeholders in Serbia to solve the problem of healthcare for the elderly with telemedicine. Thank you very much on your kind attention.
No, thank you to you really a lot, because it's amazing that, I mean, you are an hospital. So you are the one on the front line as well, like other of the other partners we were presenting. And it's, for me, strange and amazing that you were using this word about prejudice. But the reality is that we are moving to a world where doctors, are dealing with patients because of purely personal contact, moving to a world where doctors are going to be more and more ICT expert and digital doctors, let's say, not to remote the contact, the distance, I mean, to keep distance from the patient, but that we need to have more information to be more effective, to take care faster, to have more information, more data. So this concept of prejudice, for me, it's really emblematic, and it's nice that you're working not only to apply what technical aspect to a statistical aspect, but working on this, let's say, capacity building, awareness level. That is really something really important for our project, and it's cross-cutting among different pilots. So thank you very much for your presentation. And yeah, last but not least, sorry for keep you waiting. Charis, it's your turn with the last presentation. So let's move back to Greece and Central Macedonia.
So good evening from Greece, from Thessaloniki, Greece, the sunny Thessaloniki, Greece.
Well, evening, maybe good afternoon. I don't know the time zone you're facing. So the PowerPoint is going to be ready. Yeah, you can take control. The floor is yours.
Okay, so forgive me if I'm wrong. I just have to move the slides by pressing the arrows. I see.
You see an arrow after the 10. You see an arrow after 10. And if you press that one, you will move it. Okay?
Okay, thank you very much.
It's lower. Yeah.
So
you can try.
Yeah, my name is Harissos Zandes. I represent the Regional Development Fund of Central Macedonia. And today's presentation is about access to public social services by telemonitoring and support for the elderly. And more precisely, I'm going to speak about the Click for Life telecare service. So let's get started with some aging and health key facts in Central Macedonia region. Speaking about demographics, the pie chart shows that the pie charts let us know that almost 20% of residents in Central Macedonia are above the age of 60 years old. Whereas if we get more into details, we can see that 1 in 4 elderly over age 60 live in rural or isolated areas with restricted or no access to healthcare, and 100,000 over age 60 do live alone, with 50% of which needing help or assistance. But what about their medical or social profile? People over age 60 in Central Macedonia can be classified in 6 major categories. So we're talking about people that are separated from their families, people that have physical disabilities, that are cut from services, that do suffer physical and psychological distress, may have specific health and nutritional needs, and risk abuse and neglect, especially regarding older women. So the question that arises is there really a solution for supporting and assisting these people? Well, we believe that the optimum solution is telecare, And here is where Click for Life emerges. Unfortunately, I don't have a logo in English, so I use the logo in Greek. So what is Click for Life? Click for Life is a telecare service provided by Central Macedonia region to its residents over age 60, aiming at supporting and extending their independent living in their living environments and responding to real needs of caregivers, service providers, and public authorities. It is funded by the European Region Development Fund and powered, or if you may prefer, is technically supported by Gnomon Informatics SA. Now, how does Click for Life work? The beneficiary of the service is equipped with a set of certified telecare devices that you see at the right of your screen. The set is consisted of a terminal one, which can be either fixed or mobile, depending on beneficiaries' medical and social profile, and a peripheral panic button that works as watch. So 24/7, and no matter where the beneficiary finds himself, he can click. That's why we say Click for Life. He can click, he can press the panic button when in need of support or assistance. At the other edge of the line, a social worker or psychologist will respond following a specific call management protocol. And in this context, we'll set up a triangular conference call with emergency services if necessary. We are able to call for an ambulance, we're able to call for the police, for fire workers, or even the caregivers that can be a neighbor, or the relatives themselves of the beneficiary. So, briefly speaking, the services offered so far are the emergency call for help, the GPS tracking, the automatic fall detection, and 24/7 psychological support. So now that we've seen how it works, the question is, does it really work? The question may be answered from the statistics. So the statistics do show that in the last 1 year and a half, we had our call center received 7,400 emergency calls out of a total of 43,900 calls. That is 70%. And there were 201 cases that our agents called for an ambulance, 43 cases that our agents called for a police officer, and 2 cases where a fire worker needed to assist. At the same time, regarding the last month statistics, we had 438 emergency calls out of a total of 290 calls. That is 60%. So we see that more or less the percentage of the emergency calls is the same if we compare the last year statistics and the last month statistics. There were also 250 cases that we needed to GPS track a beneficiary, and 175 cases that our peripheral device automatically detected a fall. So in this context, Mr. Archelos testifies in the Greek national television. I know that no matter what comes my way, I can press the button and someone will assist. This is very important. I own a mobile, but it takes more time. At the same time, Mrs. Evangelia says, I do suffer from COPD. In case of dyspnea, the agent's response had been prompt. I feel happy, I can now be safe, and my children don't worry anymore. So we can clearly see that these people, by using this service, they feel more safe, they feel relaxed, and certainly more confident. But what about the future? I mean, so far so good. Is there a field for improvement? The answer is absolutely yes. So the upcoming services should be at first level interoperable, and at second level should be based on the cooperation between Click for Life telecare services, social services, and healthcare services. What should they include? They should include online real-time vital signs monitoring. As I said before, as I said previously, there are a lot of people who live in rural areas, isolated, They have sometimes no access to healthcare facilities, so this is very important for them. We can also incorporate the home assistance and home care services on demand, keeping in mind that these people, of course, most of the time they suffer from something, but they do not need a full-time professional specialist health caregiver. So we come with an agile solution with telecare. We can also incorporate the drugs and medical exams notifications for elderly that are familiar with technology and surely for their caregivers, children or neighbors. A medication reminder would be also very helpful. And we can also adopt mental exercise using new technologies. Well, thank you very much for your attention.
Thank you very much also to you. It's really important that in another way we are also capitalizing on the field past experience, a past solution. And that's also in the framework of the program, because we want to not invent or develop something totally new. It's not a research project, but it's a project using the best experience. In your case, it's also important that you have a broader vision of what is the need on the territory, on your region, in which way this application will imply a consequence, a description, a really engagement of different stakeholders that can be mirrored then in the policy we're going to develop, so the action plan for different regions. So thank you very much again also for clarity of your presentation and also the practical contents that it's really interesting as well. So we are right in time, I would say. I was deciding, autonomously to point question or leave space on the question during the presentation, even if I didn't see any on the chat up to now. We have about 45 seconds remaining for a question time in case anyone to post in the chat or directly taking the floor speaking. Otherwise, from my side, I would say that I'm really proud of today's event. Thank you for everybody for your contribution, organization, and so on. But even more, I'm proud of the contents we are developing in our project, because we have a lot of things that is not so usual in a European project of this kind of type of project, policy addressing project. And it's also really important that having a lot of difference among our countries, still we have really a lot of common elements that are underlined by our presentation. I go back to the point to be skeptical about ICT solution from people working on the field, to looking on the data that policymakers need to have and perceive what is be able to be performed. The availability of ICT solutions that are ready to be used from the technical point of view, but they are not yet always validated, tested, and shared as a knowledge. So really, I think there is no big difference among our countries from this perspective. So I'm really happy that transnational issues that we are tackling are, let's say, confirmed by the pilot and this experience. From my side, I don't want to keep you longer because as a moderator, for me, time is the first issue, even if content should be, I mean, it was even more important. I don't know if the hosting partner or the lead partner want to have a last word concerning. Otherwise, from my side, thank you, everybody. And yeah, we keep doing, and please keep doing as well from your side what we are developing and for the next stage of our project. Thank you very much. I don't know if lead partner want to say any word to complete. No. Okay. Then,
yes.
Yeah, sorry. I was
thank you.
Yeah.
I was carefully
from my
following.
side.
Yeah, I was carefully following, and as mentioned during our last meeting, I'm also proud and happy to see the development of the pilot activities, the progress, and now everything having compiled together in one webinar was also, let's say, amazing experience, and I hope for the people from the outside the partnership something as well. And I'm sorry to say that there are no questions, but we are all available to answer your questions. If you have any suggestions, what is needed, what you know from your personal experiences that would be important to address with this kind of project, you can directly contact the partner you know, or you can contact us as a lead partner, point the question, give us suggestions that we can also even improve what we are doing. From my side as well, thank you to all the partners, to all who present the pilot activities, and of course to the hosting partner, partner number 6. Thank you from my side.
I would like to thank you also everybody for participating, and that's it.
Great, thank you.
Thank
I
you, bye-bye.
The webinar number 2, and we will inform you about the webinar number 3. It's still one in plan. Thank you.